Welcome back to the advanced discussion track. Our next presentation will examine the effectiveness of multidisciplinary co-responder teams comprised of law enforcement officers, paramedics, and mental health professionals in addressing the needs of individuals who frequently utilize 911 and emergency detention services. Please welcome Dr. Jason Miller, the Managing Partner and Chief Clinical Officer of Athra Systems, and Judge Kazen from Bexar County.
Come on up here, Judge.
Dr. Miller, I have a question. Why are you making me talk at your presentation?
Because that way I don't have to do it by myself. How about that? I'm Dr. Jason Miller. I'm a psychiatrist. I have been a psychiatrist for a long time now, and I have worked extensively with crisis services, emergency rooms, consult liaison, forensic questions. I was originally a primary care doctor. I did that for about 7 years before I cross-trained in the military into psychiatry, and have worked largely in Bexar County with crisis services for probably the past 15 years. It was at that time that I met Judge Kazen. So this was 15 years ago. We met for coffee and started discussing the different routes of care for people in Bexar County at that time.
Dude, probably closer to 20.
It's been a while. It's been a while. And part of those conversations grew into some of the programs that now exist, which is kind of cool. And we're going to be chatting about a couple of those programs right now, one of which Judge Kazen really has championed from the beginning, which is the AOT program. And the other one is the PICC program, which is the Program for Intensive Care Management or Case Management, that is a co-responder team that is a little bit like an ACT team, but you pull in folks that are officers, firefighters, paramedics, and it really becomes a very robust case management team that has some abilities that are a little bit unique and put them in a really good place. This is just kind of the goals of all of this. The lecture is about AOT. It's also about the PICC team, but it's really about something, I think, bigger, and it's an observation that Judge Kazen and I have both made over the years, which is there's something unique about mental health that doesn't quite exist in the rest of medicine. We tend to be very siloed. We have programs that do one thing, we have another program that does something else, and those two programs don't necessarily talk all the time. We create these robust programs that go after niche populations, which is great and can be incredibly helpful until the moment that you wish those teams could talk to each other because you realize that they're sharing patients. And that was really what we set out to do with this, was we had two programs that are both excellent, both have excellent outcome measures. And we started to look at the patients that we shared. And we started to wonder if the synergy between the two could actually be something more robust than either one of them by themselves. That was exactly what we found. So the idea was to reduce 911 calls, ED utilization, avoidable hospitalizations. Not all hospitalizations are avoidable, but we wanted to drive that down. The teams that we're looking at really focus on those individuals who are resistant to treatment, but also have very high utilization numbers.
And it's no secret that most of the people that we share between AOT and PIC meet the criteria for both. They're going to be the individuals who have repeated hospitalizations, who without supervision of either the officers on PIC or a court team or an AOT team are being monitored and guided towards compliance. So they very much are the same person. The problem, as you said, is especially in our jurisdiction where you have one provider. You've got the Center for Healthcare Services, for example. They do a great job, but it's one big provider. And in Texas, most of us now have one big provider in our jurisdiction. So we don't have multiple providers, and that, echoing what you said, has happened. Within that provider, you get these silos. Everybody's in the same mission, but within their own organization, it's like, oh no, that's the director of so-and-so. Oh, you got to go over to the manager of so-and-so for that. And it's ironic to us because we're sitting there going, but you're all the same organization. And that's what this discussion is about.
No, and this is really a collaborative approach to taking care of some of the more difficult patients in our county, and it's worked out really well. At the genesis of co-responder teams in Bexar County, though I think everywhere, I do lectures for police about this topic pretty frequently, and I always give the example of, I work closely with the police, and I don't think I've ever shared this with Oscar. It was about 2 o'clock in the morning last week. They called me up in the middle of the night and they said, hey, there's a robbery in progress down the street from you. It's gonna be a minute before we can get patrol there. Would you mind go checking it out? So I jump in my Jeep and away I go, right? No, of course not. Like, that's ridiculous. They're not gonna call a psychiatrist to go do this. And yet, I call law enforcement all the time to go interact with the most gravely disabled psychiatric patients. The irony is not lost on me. Officers have been increasingly tasked with doing very heavy mental health work. And so co-responder teams have grown out of the need to provide extra training for them, to provide extra backing for them, to embed a mental health person into those calls so that the officer isn't just left to their own devices, which are often very good. They outperform, I think, anybody's expectations given their limited training in this. But you put somebody in there who's got a master's degree in counseling, and suddenly it's a totally different ballgame, which is wonderful. So the PIC team gets started in Bexar County back in 2019. It's a collaborative approach that is couched within what's the Southwest Texas Regional Advisory Council, which is STRAC. But it's made up of SAPD, we've got the SA Fire Department, we've got CHCS. It is funded by a consortium of people. One of the things that we understand is the patients that we're looking at are incredibly high utilizers of hospital resources. So in our city, STRAC has done an amazing job of pooling funds from hospitals to ultimately save the entire system money because it was money they were gonna spend anyways. And they didn't have a choice in the matter already, so pooling their money to do something more proactive made a lot more sense. Primary role of the PIC team is to provide aggressive referral linkage, transition to the next level of care. We call them kind of affectionately therapeutic stalkers. They go out into the community, and wherever that person is having a problem, they show up. And not shockingly, the first couple of times they show up, either in an emergency room or on their doorstep, the patient will frequently say, I don't need your services, no thank you, I'm not voluntary for this. And they just keep showing up. I'm not gonna force services, but if you show up often enough on enough bad days and you become a consistent factor in the person's life, eventually they start to go, hey, these guys actually seem to care about me. I tell the PIC team all the time, we are the last line of defense. In our community, there's the ACT team, they do an amazing job. We've got MCOT, they do an amazing job. When all of those things have failed, we call in the PIC team. They're the ones who are looking at individuals who've had a high number of emergency detentions. And as good as that team is, we still have what I would consider treatment failures.
It's a good thing right now to actually mention what STRAC is, for those of you who don't know. In different jurisdictions, the hospitals get together, and it originally was born from crisis management during hurricanes and the like, so that, or nuclear explosions, so that when you had to share emergency room beds, we had a central coordinating organization that could say what was open and what wasn't. That was a type of navigation. Well, that's since grown, and within that collaborative now, the hospitals, psychiatric facilities, have a pool of money, and to some extent, and they fund these types of programs that will have an impact on their hospital bed emergency utilization. So it's really not an LMHA thing, local mental health authority thing, although it can be. In this case, it grew out of the private hospitals coming together and recognizing they needed a law enforcement team or groups of them that could get out there and keep them out of the hospital and divert them somewhere else, much like you saw that they physically have done here at that center that we took a tour on yesterday.
Very good. And the population that we're looking at here, again, from an AOT or a PICC team standpoint, they're really similar populations. I should have started this with how many of you guys work with AOT teams, just by a show of hands? Oh, so yay. Lots of people are touching on AOT teams.
I remember a day when there was only one hand.
Yeah, good ideas tend to spread, right? Like it's a great way of doing this. And so lots of you are super familiar with AOT and how it operates and sort of the goodness of it. I mean, I'm a psychiatrist, and the goodness of AOT for me has always been that I get to remove the parent, the guardian, the authoritarian figure that lives in the household. They don't have to be the bad guy anymore. They don't have to be the one who's constantly enforcing medications, constantly reinforcing staying out of a hospital, trying to keep that person with bad illness on track with their medication regimen. Now that family can reflect and go, well, you know, the judge really wants you to do this. And there's an enormous power in that. And if I had to sum up what I love about AOT, it really comes down to I get to point to Judge Kazen and say it's his fault.
I get to point back.
And
actually, that was a photo op. Let's do that again.
There we go. So really difficult populations that we serve. One of the things that, and this won't be lost on all of you who work with AOT, the folks that are the most resistant and the most difficult to treat have generally some combination of a serious mental illness like schizophrenia, usually some sort of a psychotic disorder, a co-occurring substance use disorder, and usually some sort of chronic housing instability. Does that sound about right to all of y'all? Yeah, that's like everybody you treat, right? Yes, with little understanding that there's anything wrong.
And no money. And no money.
Yes, yeah, usually no source of funding. And so AOT or PICC, when you start to interact with those people, you know, you think of that Maslow's hierarchy of needs. You need to get them housing, you need to get them funding, you have to address some of those needs before you can really even think about other things. And even with that approach, which works very well, there is a percentage that, man, you still don't get them there, and it's really, really difficult. This is kind of on the economic side of it. One of the things that STRAC has done an amazing job of is they quantify cost savings, and they employ a group that looks at the economic burden and the economic benefit of the programs that they institute, and that's really nice. Typically, being able to quantify those things is difficult. Medical economics is difficult. What I have done in this presentation is giving you a very, very bare bones assessment of it. And it's, even with that, I think you'll be able to appreciate the kind of enormous cost savings that these kind of approaches can take. So an average ER visit, and this is just in the United States, is about $2,400. There's a range, obviously. It can be a lot more. It can be a little bit less, but it's around $2,400. When you look at somebody who's being evaluated for a mental health disorder, which means they've done a physical exam, they've done labs, they may have done imaging, they may not have, but it gets to be pretty pricey pretty quickly. Typically, individuals in these situations can get hospitalized much more frequently than other people, and an average cost, and again, just an average cost, for an 8-day hospitalization in a freestanding emergency room is around $12,000. Now, that's not what you would have paid as a consumer, that's what it costs. And so it's what it's costing that institution to have that person there, and when they don't have a source of funding, that was $12,000 they just lost. So it's a significant impact to those kind of institutions. And so if you can work with a PIC patient and get that under control for just their ER and just their inpatient admissions, if you can just lower that, you can save about $100,000 per year per patient, which is not insignificant. How many of you wish you could pay your case managers $100,000 a year? Right? Like that would go pretty far. Are you paying that? Because I could join. I mean, if you're looking for people.
She's a case manager.
And so the cost savings there is enormous. I think, this is speaking as a psychiatrist, we often focus on the good work that we do with patients and the good that it does the individual. The reality is, from a business plan standpoint, if you can't show where it also has an economic impact, it is much harder to get funding, it's much harder to get buy-in for these kind of things. So what is assisted outpatient therapy? or outpatient treatment. So it's the civil court order. Judge Kazen will do a much more eloquent job than I would on this. It is generally time limited, 6 to 12 months, and it does enable rapid re-engagement and care plan modification, especially for people who are non-adherent. You're going to be meeting with the judge, and these are things you all know because you're experts in this already. But Judge, did you want to jump in and?
Sure. So the AOT takes the intervention of the client a step further. It makes it a little more formal. I'm not going to reinvent the AOT wheel because we've talked about it enough now that I think everybody knows what it is. But now it's an order that says, I can't put you in jail, but we are going to require that you appear before the judge and adhere to your treatment plan. It turns out that just because you're ill, you're not foolish, right? It turns out that about 80% of them will at least begin the process with AOT. And at that point, if your team, if your judge, I have Judge Mo, Erica Mo, who does the day-to-day discussions with some of these people, if you can engage them and show them that you're there to help them and not punishment, the statistics are pretty much the same across the country. About 75, 80% of them will engage. So if you can take this population, wrap the belief in a court order, a requirement that they participate, and then make that transition to we want you to participate because you want to participate, the success ratios are incredible. Now, what are we having today? Well, today, AOT in San Antonio, for example, isn't the AOT it was 10 years ago. We had the state hospital we could send people to. We had longer-term beds. Almost every jurisdiction has turned into a circumstance where those beds are taken by forensics patients, right? We don't have those civil beds anymore. So instead, we developed all these processes where police officers, PIC units, emergency detentions, warrants, jail diversions, take them where? To the front door of a private hospital, typically, or a very overworked county hospital. And their stay that used to be 30, 60, 90, 180 days is 5 or 10 days, or 3. Yes, absolutely. We're all experiencing that. And for AOT, that's really hurt because, hell, we're barely even prepping the paperwork before they get discharged in many occasions. However, and we have also, let me add, we've also lost a lot of supportive housing. We used to have this big, huge Cloud Haven, which was a boarding home. We would put them in as part of AOT. The county would pay for them. The LMHA would pay for it. Well, those monies have dried up as well. So we're working with people on AOT who are at the Salvation Army, who are at Haven for Hope, who are out in the streets, in tents. So how do we get around it? And then all of a sudden, Jason, to his credit, says, hey, I've got a unit that does that. We go out and we actually go chase them down. My AOT caseworkers do a lot of chasing, but they're not police officers. They go home to their kids at 5, hopefully, all right? But if you can take that team and use them as a supplement to AOT, which is a court order that says, I'm not going to keep you in a hospital, I'm going to let you out, but you've got to report to the team once a week. Oh, and by the way, I can't take you in because you're violating, but the minute you start to deteriorate, I have the power to pick you up. They listen for the most part. We begin to engage for the most part. But the ones who leave and the ones who are a true failure, you then add the diversity of a PIC team. Police officers, which are formed of a police officer, a firefighter, a therapist, a caseworker, who are out on the streets engaging them. You put those two things together, and now the court, they often say AOT is a toothless tiger. It's not so toothless now. We're still engaging them because we want them to engage, but now at least I have eyes and ears. I refer to it as a toothless blind tiger. At least we're not blind anymore, because if we start doing this, and we've tested it on a few people, this collaboration, PIC becomes our eyes. PIC will tell me in a day or two and work with our team to re-engage someone, as opposed to the team saying, Judge, we've looked for him, he disappeared. Well, we'll pick him up when he gets back in an emergency room. That's what this conversation is about. It's about discussing the ability of an AOT, a court, to tap other resources and be collaborative in working with each other and making it a protocol. Again, I'm not going to get into the long AOT orders, but I hope that kind of explains the role of the AOT. We put them on an order, they're supposed to appear, we've got a team that wraps around them. In the old days, we had housing and we had some more supportive services. Nowadays, what did we say yesterday? How do you eat an elephant? One bite at a time, but it's still an awfully tough chew, right?
So historically, AOT has been around really for a while.
Yeah, I think we started our first, when there was no AOT in Texas at the time. It was on the books, and Judge Spencer, who's the judge, who's my mentor, had one caseworker who was kind of out there following a person or two. And I had just come off the drug courts. I was also in Bexar County, one of the first judges. If Judge Speech is here, he was the other one, who started the drug courts in Bexar County, and Judge Alonzo. Nobody had ever heard of a drug court. Now they're everywhere, right? So I took that model, overlaid it on AOT, and said, well, why don't we just do it here on the psych side? We've got the law. And that would have been in about 2006, maybe 7, somewhere in there. Yeah. That's when we did it.
Yeah.
The first one.
And so many of you, again, you're AOT experts. AOT gets a big leap forward with Kendra's Law, which of course was a tragic incident where a young lady was pushed to her death on a New York subway line by a person with uncontrolled schizophrenia who had a long history of hospitalizations and a lack of compliance with his outpatient treatment. And this really kind of pushed forward this idea of AOTs, but it takes it a while to take hold. I mean, Judge Kazen's was one of the first ones in Texas.
The first one.
And it was, I had come online as a psychiatrist in our community around that time, and it was just like this revelation that I could get somebody to comply with treatment with the aid of a judge.
Here's where we break into because we are the three amigos. Wait, there's only two of us. That was a lot funnier in my head than out loud.
And not surprisingly, there's now been mounting evidence, and really for the last couple of decades, that AOT programs work really well. Judge Kazen and I, at the very onset of talking about AOT, he talked a lot about the black robe effect, and it's real. That's a real thing. My patients can appreciate, even the ones who are really, really ill, going into a courtroom and saying, no, really, we really want you to comply with treatment. And if you don't comply with treatment, then we take that to mean that you're not doing well and that you might need to go back to the hospital. That's not a threat. That was what was going to happen anyways, right? Like, you don't comply with your treatment, then you decompensate, we take you back to the hospital. But now it gets captured in their mind as this is a requirement. And most people really do, they grasp that, even the ones who are really, really sick. Not all of them. There's those who do not. But it really does make a big effect.
Half the battle, as you know, with AOT and PIC is to develop that trust with the officer who's knocking on your door, visiting your camp, making sure you go see your doctor next week, taking you if they have to. But the part of the model of AOT, a significant part of the model, is getting them to vest in their own treatment and getting them to understand that wellness as a habit is much better than illness. And again, may I just a second with an old story? So there's a guy driving out, I'm always trying to be silly, but there's a point behind it. There's a guy driving in front of the San Antonio State Hospital. He gets a flat, and he changes the flat. And while he's changing the flat, he loses the 4 lug nuts. Those are those bolts that hold the tire on in the grass. And he's looking for him, and he's cussing up a storm. And behind the fence of the San Antonio State Hospital is a patient hanging onto that fence. And he yells out, he says, hey, dude, why don't you get 1 lug nut off each of the other 3 tires, and that way you'll have 3 lug nuts on each tire, you can make it home. And the guy turns around and says, hey, how'd such a smart guy like you wind up in a place like this? He says, you know, I might be crazy, but I'm not stupid. And that was told to me by a patient once in a hearing where I was trying to make a point. He says, I might be crazy, but I'm not stupid, Judge. And amazingly, it works. In about 80% of the cases, they're willing to work with you if you give them a chance. You'd be surprised what having the PIC unit, a law enforcement officer, and a judge for the very first time in their life say, what can I do for you to make this work? What are we doing wrong? You'd be surprised what effect that black robe effect has. And you're a judge. They might be ill, but they're not stupid.
And the co-responder teams, and I think it's a really nice segue from this. at its onset, the co-responder teams weren't just about augmenting police officers. It was an understanding that not all patients respond to people in the same way. So as a psychiatrist, I have had plenty of really psychotic people look at me and go, "You're a psychiatrist? I'm not talking to you. Not gonna do it. All of you people think I'm crazy. I'm not gonna talk to you." One of my officers comes on scene and they're like their best buddy. It's like a totally different dynamic. Same thing with the paramedics. We have a paramedic who's a gentleman who's been in the fire department a really long time. He's been around forever, and they just love him. Because he's not a psychiatrist, he's not a threat. He's not an officer, he's not gonna take him to jail. He's a paramedic, he's there to like check their blood pressure and stuff. And he comes in under the radar and they are happy to talk with him. And then he becomes that bridge of now we'll talk to the psychiatrist because, Melvin has said that this guy's okay. If Melvin likes him, maybe it's all right. Much the same way, people will respond differently to a judge than they do to their doctor. Once we get to the co-responder teams, we start to think about what that kind of high-level workflow looks like for us. And in essence, it's this. Whether AOT or the PICC team is interacting with somebody to which they've reached some logical endpoint. The person, despite our best attempts, still just won't comply. They just aren't getting better. We can't quite move them in the right direction. Again, not shockingly, a lot of the individuals in this, and I'm sure Judge Kazen and all of you who work with AOT will appreciate this, a lot of them are on the border of needing a guardian, right? Like they just don't have great executive function. When you think about people with bad schizophrenia by itself means that somebody has the executive function or the ability to think through tasks that is equivalent to somebody with a moderate level of Alzheimer's. Alzheimer's is graded as mild, moderate, severe, and in the moderate realm, you live in a nursing home. And yet, our schizophrenic folks who have the exact same level of functioning are out on the streets and we're hoping that they comply with treatment and show up to clinics. They just can't. And so we end up thinking about guardianship. Well, there's a bunch of steps between guardianship. Guardianship doesn't mean anything if the person has nothing to work with. And so it takes a lot of case management and time to get somebody to a point where a guardian can even be useful to them. AOT has been a great bridge for that. It's that ability to show in that structured environment that they'll actually succeed, that they can do well. And at that point, then getting a guardian starts to make a lot more sense.
Or placing them in a supportive living, like their own boarding home or their own place. Because
Exactly.
you've got time now to get their benefits hopefully in place and work with them. Ironically, we've lost, like I said, a lot of the housing component for now. We're fighting to get it back, but this, in the cases that he did, what we lost from having them in a supportive housing that could report to us right away and let us know that he's not doing so well, some of it we picked back up by having a co-responder team visiting with them on a regular basis, on a daily basis. I'm going to add one last thing about this. So AOT, for those of you who are great fans, you're great fans. For those of you who aren't, I urge you to think about this. Are there going to be failures? Yes. We're dealing with the worst people in the worst category of success. Absolutely. Is a judge going to issue an order that's going to be a great waste of time? Yes. But even there is success. Would you rather have that guy on the radar of a court order now, as we're working to figure out how to do this, on the PIC unit's census as well? Would you rather have them on the radar so that if they begin to deteriorate, I've got a court order and a mechanism and a team to bring them back in for stabilization within a day or two? Or would you rather have them off the radar without a court order, so after they're discharged from the hospital, it'll be about 6 months before we see them under a bridge, unmedicated for months and months and months. And now to get them stable again is going to take another 2, 3, 4, 5 months. Instead of intervening right at the beginning of the crisis, and what's the stabilization usually, 4 or 5 days back on your med?
And so again, to Judge Kazen's point, the idea that there's going to be treatment failures on either one of these teams, I don't think is lost on anybody. The AOT team does not fix everybody, right? There are gaps in services. There's things that we can't account for. There's people you just can't find. One of the the really nice things that STRAC has done in our region is our law enforcement can see every time there's an emergency detention done on one of these patients in real time. And so that person gets an ED done and they actually dispatch the team to meet them at the hospital. And it happens in real time that day. Every time they get in trouble, they see the same people over and over again. And eventually they're like, okay, I guess these are my people, because I've gotten to know them incredibly well now. It also makes it so we can find them, because every place that they pop up on, we get a notification and we go there. And it's kind of a drop everything and go find that person. Now there's people we don't do that with because we've seen them 4 times that week and we don't have to have a clinical moment with them that day, but we do it a lot more often than not. So in those kind of folks that you've had that treatment failure, then you look to the other side of the aisle and you look at AOT and you say, what can we do together? Same thing with AOT with PIC, is we're having a really hard time locating this person. Can we get some PIC resources? Again, this is evidence snapshot. Since the onset of Kendra's laws, they can see large reductions in homelessness, arrests, substantial net cost reductions. You read stuff like that and you don't really appreciate what it means, but we'll talk a little bit more about that evidence. With growing adoption, there's certainly outcomes vary by design, local context, of course, but generally what you see is a decrease in detainments, arrests, hospitalizations, and overall cost. Because we're going to run short on time, I want to get to the parts that are fun. This is just kind of some of the things that we look at in terms of KPIs, things that we're looking at that are our measures of success. Use of force with co-responder teams, it's rare. It's rare that there's a use of force. And what you'd like to see is overall that a use of force has gone down in the mental health population. And that's probably one of the bigger goals of having co-responder teams. Certainly there's guardrails here. You can't just put somebody on one of these teams just for the heck of it. We have a lot of, because we have so many ill people in any given large urban environment or in any large enough catchment area, you're certainly going to get individuals who are going to meet these criteria without too much difficulty. This is a very busy slide. You don't need to be able to read it. That is not the point of it. The point of this slide is to show that there's lots and lots of points of contact for a typical PICC patient, and that their outcomes get better the further it goes. That's all I'm trying to show here. I point that out to say that AOT or PICC are complete teams. You don't have to look to the other side of the aisle. You don't have to go get other resources. They do a great job on their own. What we're talking about is in those moments where you've reached some end point. And so this is one of our first cases that we did. It was a 50-year-old female. I left all of the diagnoses that are up there because I think it illustrates the point that we often have this mixture of diagnosis that aren't necessarily true. But it depended on the day that you interacted with them in terms of when they actually got that diagnosis. So one of them was schizoaffective disorder, the other one was bipolar 2. For the clinicians in the room, you're like, those don't really totally go together. They don't. They got the bipolar 2 diagnosis on a day when they were relatively stable and looked very different than when they have a very psychotic presentation, though in her case she had often a very psychotic presentation because she also used a lot of methamphetamines. And it made everything look worse, right? And that mixture makes it really hard to get an accurate diagnosis other than to say that they just have a substance-induced psychotic disorder. So she had had 13 emergency detentions over the course of about a year. She gets connected to AOT in October of 2024, and her ED utilization goes way down. She goes from her 13 ED visits to 1. Which is pretty tremendous. Just that cost savings alone was a couple of our folks' salaries for that time period. Just that cost savings. You replicate that over about 100 patients, and suddenly you're looking at something that is much, much larger. She ended up residing in a place called Cross Point. She was able to maintain her sobriety from methamphetamines. And I will tell you that she's somebody that we had not been able to accomplish that with PIC alone. When we added on AOT, that black robe effect, that final piece of the puzzle came into play, and she was like, oh, I really have to do this. This is a real thing. Yeah, I kind of don't want to comply with treatment, but the judge really wants me to, so I'm going to do it. And it made a tremendous difference for her. Cost savings just in the ER visits was $29,000 over the course of just that short period of time. So that was just that cost savings. Forget about housing, forget about other hospitalizations, outpatient visits. That cost savings was all by itself excellent. Other case, 45-year-old female, schizoaffective disorder, substance-related, using methamphetamines. She had engaged with PIC for a long time. So she'd been on the PIC team for 5 years. For a high utilization team that goes to your house, goes to the hospital, goes to the ER, goes to the jail, goes to wherever that patient is, the fact that she stayed on our team for 5 years was kind of crazy. I mean, that's just an enormous amount of resources we were spending on this young lady. She had 24 emergency department visits over the course of about 4 years. So a decent number, actually not as high as some, but a lot. We connect her to AOT in February of this year, and her ED visits reduced to 0. She has not been back to the emergency department. Her needs are getting met in the outpatient setting, and that, again, cost savings alone, she was averaging a ER visit every other month. She was certainly going to hospitals a lot more frequently than that. And we aren't even talking about the economic impact of that. The ER visits are oftentimes the easiest thing to quantify because there's an emergency detention that's tagged to it so we know when they go. The AOT team's ability to interact with the PIC team, provide that extra level of structure, took this person who, after 5 years of intensive case management, had not been successful and now was successful by any measure. Cost savings, $14,000 just in ER visits, just over the course of a year. To make that a bigger economic impact, one of the last pieces of economic data I looked at for the PICC team, where we'd done really a comprehensive evaluation of how much money we had saved, was after we accounted for the cost of the PICC team, we had saved the system, it was actually $3.2 million. So really significant. That was just over the course of 2021. Again, none of this is risk-free. These are real people who have rights, who you can't just put them in these programs because you think it's a good idea. They really do have to meet criteria. But at this point, these are individuals who have been emergency detained a lot. They've been in lots of hospitalization. They've failed other resources. That's actually how they come to us, and that's ultimately how they came to AOT. To which you can say, well, which one's which? Well, the PICC team is tied into the emergency detention, and Judge Kazen's team is more tied into that post-hospitalization period where somebody's had multiple hospitalizations and is failing to comply with outpatient treatment. Not lost on you, that's the same population, right? Those are the same people. So considerations, and these are things that I thought about before I knew Judge Kazen was gonna be here, so individuals who fail this AOT PICC initiative, they may require guardianship. Those are people who maybe require yet another level. Judge Kazen and I will do a lecture next year on the guardianship program we'll create, because we want to do more with that, but that'll be for next year. In Bexar County, Judge Kazen does AOT, but he also does guardianship. And that puts us in a great position as we think about people who might need that extra step. What's the evidence that they need the extra step? Because the team Judge Kazen runs couldn't get them where they needed to be because they didn't have that ability. I don't know if you wanted to comment on that.
Yeah, and so guardianship is a horizon that we need to explore because it comes with it a lot of challenges. It's still just a piece of paper, right? But what happens if you use guardianship together with a PIC team, together with an AOT order? Then is it possible to help people with a supportive decision maker, such as a guardian, fill those gaps in their continuum of care? as a practical matter, if it's just a guardianship, it's kind of tough when somebody's mentally ill. They're going to do what they want to do, right? But if you've got somebody with a PIC team, day-to-day contact, a treatment team, AOT, a judge, court-ordered, and a guardian to make decisions, it seems to me that's the horizon we need to explore. So,
So super helpful. The argument that we're making today is not that everybody needs to go out and have a PICC team as part of your AOT initiative. Sure, that would be great. Not all counties can get there. Not all cities can get there. Totally understand that. The real subtext of the lecture is to look for other resources around you. AOT can be a standalone service. It often acts that way, right? I mean, you've got your own clinicians, you've got your own case managers, you're getting them to the appropriate psychiatric resource, but don't be afraid to look at other resources and other folks who can be pulled into this, because we as mental health professionals, and I own this because I'm one of them, we get siloed really quickly, and we forget that there's these other programs that do similar things and could be really helpful for us. A win, and this was my point when we sat down to talk with AOT, is this is not about us taking your clients. This is about us augmenting both of our abilities to serve the same people.
So, and many of you have heard me speak through the years, and a consistent theme is not just AOT, is that we need to push back on the walls of our silos. Because we just do, even when we're doing the right thing, everybody's trying to do the right thing their way. So I'm going to push back as an example. We're here at this commission, and there are brilliant minds in here, and there are discussions going on over lunch, and I'll give you one. Now I'm going to. This is how the conversation begins, right? I'm going to surprise you with this one. Lisa, are you here, Judge? Did you come over here to this one? All right. So we have our 46B and 46C magistrate judge that does the hearings on competency restoration. She works for the center, right? And she was telling me, you know, we've got all these people. I really could use another probation officer. Where are we going to get the money for it? I said, what do you need it for? And she says, well, you know, we've got a lot of these people who have been found not guilty by reason of insanity. We've done a lot of hard work to get them out an outpatient, and then kind of the court doesn't see them again until either they've completely failed or they've completely succeeded. And I'm wondering in this conversation, by the way, this is an example of what you all can be doing through all of these commission type meetings. Jason, what are the chances of PIC being that quasi-probation officer, taking some of these people who are already on your census but are out in the community on, not guilty by reason of insanity, and wrapping some of their supervision on those people, and then having the judge create her own AOT version on the criminal side.
Right. No, I mean, there's
Thought.
Yeah.
See, that's how the spark happens, right? And I'm not going to send them flowers, but you know.
But that idea
That was funny. You can laugh.
the idea that these populations have giant overlap. The person who is not competent to stand trial and is out on outpatient competency restoration may have also met our criteria to be on the PICC team.
Yeah. So let's push against the walls of our silos, even in Bexar County, and let's go even further. Let's just talk about the people who are out of the criminal justice system because they're not guilty by reason of insanity, and now we got to provide services for them until they're no longer needed. There's no real definition for that yet, right? Let's look at pushing the walls of this silo and seeing if we can't collaboratively work together there. I just did that by way of an example of how ideas can happen that fast. And all they can do is say no, right?
And what I have listed up here, for those of you, I saw somebody taking a picture of it, are sources of funding. I wish it was as easy to get funding as it is to just list some things. It is, every single one of these is an uphill battle. Every single one of these requires all sorts of difficulty, and it's a political exercise always to get funding for things. One of the things that we haven't explored, and I'll just put this out there as an idea, is especially for high utilizers, they're not all unfunded. We think of the LMHA world as being largely unfunded individuals. The PICC team actually has the bulk of them now having funding because we went out and got them funding. Well, who does that cost money to? Well, that costs money to the insurance companies. So it is at least possible to appeal to an insurance company for funding for this kind of program, because that's the person who's getting their money saved. And it is way cheaper to employ one of these teams than it is to hospitalize these folks 3 or 4 times a year. So it is an argument that can be made. Is it an easy argument? No, because it's getting money from an insurance company. I don't know how many of y'all have been successful at that. I've known some entrepreneurs who've managed it, so it is possible. That brings us to the end, and we have 55 seconds for questions. Yes, sir.
You mentioned guardianship as a tool, but you were mentioning it on the back end after AOT. I'm going to pick on Judge Kazen a little bit. Do you ever use, because mental illnesses are cyclical, and you come in your peaks and your valleys, permanent guardianship for me is problematic because it's very hard to undo it. Do you ever use temporary guardianships to secure those Social Security funding, Medicaid, housing, Section 8, all of that at the front end? Because a temporary guardianship lasts 60 days.
Right.
And we've had limited success with that. And then, diverting into AOT out of that temporary guardianship and using them simultaneously.
I think the answer for that is, it depends on the jurisdiction you're in, first of all. So Houston's got this huge guardianship program, because they can, and I'm glad they do. San Antonio's got like 8 guardians for the whole city, on a guardianship program. The answer to your question is, AOT is never contemplated, or PIC, or any one thing we do to be the silver bullet. We need to do guardians, we're going to implement guardians, and guardians are going to fix everything. That's not, we're just a piece of the puzzle. So the answer is, to the extent that we can find that person who needs either a temporary or a permanent guardianship, to the extent that we believe it'll get them to a point where they no longer need a guardianship, we need to explore that horizon. But none of this will ever be A plus B equals C, do it every time that way. So I concur with you. Guardianship's tough. I don't know if we can do it, but it's a horizon we need to explore.
We've also had really good success in Denton County, picking up some Amtrak to Berry County.
I think we have reached our end point. Thank you so much. We appreciate it.